And we will now start. Now, the etiology varies from place to place. You know that America has different set of diseases, mostly metabolic diseases or masquerades, malignancies. But we do have infectious diseases. So Western diseases are entirely different from Eastern diseases. And if we write the textbook written by them, which is written some 10 years back, it is only history. It is not the present day representation at all. We will see what it means. Because we follow such textbooks, our uveitis clinic has more than 50% of idiopathic cases because we are not identifying the causes. When we identify our own causes and when we understand and insert it into the literature, slowly this idiopathic will become 50 to 30 at least. 30 is accepted, but more than 50 can never be accepted. If it is more than 50, we are not diagnosing properly. This slide, I really wanted to make it as the first slide because always when you hit a dead end, there may be two paths, and usually a well-traveled path will be having a good light and it will be neat and clean, easy to walk. And the other path will be dark and it may have thorns, but still we have to explore both because life is not that easy. We have to work hard and we have to understand, we have to look in a different angle to really understand what we are going to achieve. And 1993 to 2023, I should say, I have not changed this number, but we are still doing research. So it is 3 decades and we have found out 3 important diseases. One is leptospirosis, trematode, and as he mentioned, West Nile virus. It is no more presumed trematode. It is now proven as trematode granulomas with molecular diagnostic. I am just going to share how ignorant I was and how many mistakes I did before we reached the definitive diagnosis. Because that will make you understand that the life is not that easy. We have to take a hard line. And 1993 November, what happened is there was a very, very heavy monsoon rain. And that was the year 92, we have started uveitis clinic. 92 November, we started uveitis clinic. And 93 November, I had 1 year experience of being in uveitis clinic in Tamil Nadu. And suddenly I saw a trend change. Every day, believe me, every day, few young men came with acute panuveitis with hypopion. You will now understand. Acute panuveitis with hypopion, according to the textbook, it is only Behçet syndrome. And Behçet syndrome cannot occur in epidemic. So it was not fitting with any known entity. And it is not anterior uveitis with hypopion to call as HLA-B27. And HLA-B27 also cannot be in an epidemic. So it is neither HLA-B27 nor Behçet's nor endogenous endophthalmitis. It was not fitting with any known entity. I was extremely upset because when you are young, as young as 33 years old or 32 years old, you don't want to accept anything, any failure. Now in this age, I see failure and success at the same frequency. But in those days, I used to be very vexed. And every day, night, I'll be thinking, oh, there are some new entity which I do not know. And I started asking further history from these patients. They all had history of fever 1 or 2 months before. And many of them were flooded parts of Madurai. There is a very funny area called Sellur in Madurai. Even for a very mild fever, mild rains, they will have floods in the roads. So Sellur is known for waterborne diseases. So what I came to a conclusion is, it should be a waterborne disease which causes fever, that causes uveitis. But this was not fitting with the literature. Literature was not giving this definition at all. But you will be surprised, within 2 months, believe me, in November it started. In January, I had 250 cases. If it is 1 or 2 cases, we can write idiopathic and be quiet with that. When it is 250 cases, it is something like patients are hammering on your head, find out something. You cannot keep quiet. And I started treating with steroids. They were getting back vision, but still I was much worried about the etiology. So I started working on known causes of febrile illness in our own microbiology lab. After all, it was only malaria and typhoid. For all other things, we didn't have any lab kits. And we only had a list of diseases, which I listed in a paper. But what I did is, I didn't keep quiet. Believe me, at that time, I had 1 year old, 6 months old newborn baby at home, a feeding mother. But still, I did not keep quiet. One second. I did not keep quiet. What I did is, I went and met many private practitioners in their practice and asked them whether they are seeing any endemic or epidemic diseases. They told, yeah, our practice is very good and we have quite a lot of cases. You don't know the etiology. It is very simple. It is seasonal fever. I was so shocked. The doctors are feeling happy for increased number of patients. Because in that age, I was very ethical. I thought it is very, very unethical for a doctor to talk like that. Anyway, I didn't get the answer and under private practitioners. So what I did is, I went to general hospital and I was asking my people, my own teachers, whether they see any epidemic fever. And they were very upset. They told, oh, ward full of patients, we are not able to manage. And sir, what is the reason? It is seasonal fever. So everybody accepted that as a seasonal fever. But I cannot keep quiet. So I went to Madurai Kamaraj University. It is so difficult to go everywhere after working hours because you will not get leave at all. And after 6 o'clock, your university will be closed. Sunday it is closed. Somehow you find time and go to the university. I went met a few scientists and I was asking, is there any epidemic diseases in Madurai? They were laughing at me. Doctor should understand the disease and diagnose the disease, and it is not the scientist. Scientists will be working on and doing research, and you have to diagnose. Yes, it is true. We have to diagnose, and then they will start the research. So I turned back with a sad face from Madurai Kamaraj University. Then I went to Madurai Corporation. In Madurai Corporation, the staff were very, very uncooperative. Because they got irritated. Once they make a news that there is an epidemic fever, the government will get alert and they will be penalized. So he wrote in a paper, there is no epidemic disease and endemic disease in Madurai. He signed and put a seal and gave it to me. I was the doctor who was seeing the patient, but he put a stamp and I wanted to close my mouth. Then I went to microbiology department at last in Madurai Medical College. Here is a person, Dr. Chandrasekhar. He has done his PhD in syphilis. And he is the one first to propose the name of leptospirosis. He told, I know a syphilis, I have studied syphilis. It is a spirochete. I know another spirochete, leptospira, that can cause fever and that is waterborne disease. Maybe you are getting leptospirosis outbreak. He is the one who gave me the first name, and this happened after 2 months after my first case. But unfortunately, he had only one instrument, dark field microscope, which is very, very less sensitive. Very highly sensitive, highly negative specificity, which means that any blood, any water, any fluid kept under this microscope will show spirochete or spirochete-like organisms, spirochete-like artifacts. So this instrument is no good at all. So I was again broken into pieces, where to go. Then I was asking several people, and one of the scientists, one of my relative was a PhD person. He told, there is one doctor, Professor Rathinam, veterinary surgeon from Madras Medical College, and he is in Chennai. The junior doctor should understand that this is 1993-94, okay? At that time, we did not even have landline connection at home. And he also didn't have. He's a poor veterinary surgeon. He didn't have. There is no way we can talk over phone. If at all, if we have to talk, we have to find his address through someone who is known to us. It is not email era. It is not Google era. It is not PubMed era. We didn't have computer. We didn't have cell phone. We didn't have landline. So I had to go personally to meet this person. And the Chennai, I have never gone alone in those days. At home, people were so shocked. I was telling that I'm going to carry the sample. I'm going to search this man in Chennai and I'm going to give my samples. They were really scared, because you are going to search a person, you do not know where he is. I told some area Madhavaram, he is working and he is living in Pallavaram. But in 93, these areas were outskirts of Chennai, not as crowded as now. So whether to take a auto, whether to take a bus, I didn't know anything. You can understand this. Anyway, I went with the samples. I reached his home at 6 o'clock because I took overnight bus, and I didn't know how to transfer the samples. So I had my own thermos flask. I had my up and off tube with the samples and controls marked over them, and I put in ice as well as, and the thermos flask, I closed it and I carried in my hand. It was a very, very indigenous way of handling the sample, but I didn't know because I'm a doctor, I'm not a scientist. And I reached his home at 7 o'clock morning directly. Somehow I found the address and I reached him, and he was such a wonderful person. He's a veterinary surgeon. So he was so surprised to see a doctor from human side. With a broad smile, a human doctor is coming to me from Madurai, all the way from Madurai, to talk about leptospirosis. I am so happy to help you. And you take a bath in my home. You take food in my home. I will carry these samples. I will test and come back to you within 3 hours. So it is such a wonderful thing, because you cannot go and stay in a lodge in 30 years back. I mean, in 1992, you are not bold enough to stay in a lodge. Now, in my age, it is possible. That age, we were from a village, Madurai is like a village. I do not know anything at that time. So I took bath and I had breakfast with his wife, and I was waiting. He came in the evening with a very broad smile. He told 15 samples are positive, highly for leptospirosis. All your controls, 20 controls are negative. So this is really outbreak, and we will write a paper on that. So he only taught me that it is an endemic disease in villages and epidemic disease in monsoon. So I had to, this slide is only to say that we have to travel all the way to Chennai to do a lab test, which is not known to any of the doctors. So this doctor only helped me in writing my first paper, Indian publication, leptospiral antibodies. See the title, no? Because he himself was so surprised. Leptospiral antibodies in patients with recurrent ophthalmic involvement. Because he didn't want to put it as uveitis. I told uveitis, but he is not well versed with the term uveitis. So he told, no, I am seeing antibodies in your patient. That's all. That is the report I will give. I will not say that your uveitis is due to leptospirosis. He was so cautious. And it came in the Indian Journal of Medical Research. Then I came to know that in order to prove, we have to approach world reference labs. Where are world reference labs? All those world reference labs are in developed countries like America, Europe, Australia, and one in Brazil. How to reach these countries and how to give the samples. And by this time, I had 700 samples. So because patients are pouring out, and I had some sense to collect serum from everyone to have age-matched controls then and there. So I can do research at any time. We did not have any AMRF at that time. Our Medical Research Foundation was not existing. So I stored my samples only in coffee shop refrigerator, because I did not have refrigerator at home even. So it is 1993. Then finally, we approached all these labs through volunteers. Dr. Emmett Cunningham is my very good friend and colleague. He is in San Francisco, And this man is another, next man is a computerist who came as a volunteer to Aravinda Hospital. He was willing to carry the samples without informing the customs, because custom will not allow. Those days, ICMR was not even aware that the problems of exchanging the samples. There was no rule at that time. So I gave all the sample to this computer person, and then Emmett received it in the airport, and he sent it to CDC with my name on the requisition. And CDC, we sent some 100 samples, and 100 samples we sent to Netherlands, because Netherlands, I visited Netherlands for a conference by that time. So I carried myself. The next year, I went to Australia for a conference. I carried myself with me, and all the 3 labs proved beyond doubt that it is only leptospirosis. That was such a wonderful experience. And the Netherlands scientists went one step ahead. They allowed me to set up a lab, leptospira lab, with the 51 serovars. So these were the scientists. I had to go fast because of lack of time. And finally, I had thousands of cases. The first 73 proven cases by CDC was published in American Journal of Ophthalmology. Believe me, there is no email. So every paper has to be written and typed by a typist, and it has to be sent by surface mail. It will take 1 month to reach American Journal of Ophthalmology office. Then they will send the correction by surface mail. That will come to me after 1 month or 2 months. Again, I have to correct and send. It was the scenario. We are the lucky people to enjoy those days and the present days. You people will not know life without cell phone, but we know the life without landline. So finally, we classified and characterized the disease, non-granulomatous panuveitis with hypobion, with early occurrence of cataract, retinal vasculitis, papillitis, and membranous vitreous opacities. Free-floating membranous vitreous opacities were indicative of leptospirosis. So after that, we had several publications, and we also had recently published diagnostic criteria in Ocular Inflammation and Immunology Journal with a statistically proven method. And we have also validated with a further bigger sample also. So now we have taught the literature how leptospiral uveitis will look like. And the Indian Journal of Ophthalmology has recently selected our paper as the best paper because we found out this epidemic outbreak. So leptospirosis is over. Why should we bother about this disease which occurred as an outbreak in 1993? No, we are not worried about 1993 anymore. This disease is endemic in our farmers. Every day they suffer from kidney failure, liver failure. 4% of patients die out of leptospirosis. So it is very, very important for us, for our physician to know about leptospirosis. Ophthalmologists have found out, and we are seeing cases almost all these 30 years. But our kidney doctors or hepatic doctors or neuro doctors are not diagnosing leptospirosis. It is our time to teach them what we know. Then the second disease is originally called as conglomerate tubercle, and anything of millet size is always known as tuberculosis in India. This is how liver tuberculosis look like, a millet-shaped lesions. So it is not a mistake, but even Duke Elder called this as tuberculosis. But what happened after starting Uvea clinic, pooling of cases occurred, and my failure rate in this disease was very, very high. Tuberculosis treatment was not helping me at all. Children were going blind. So I thought I will ask ICMR for a grant. I got it, and I started working for tuberculosis. We did culture from these granulomas. We did PCR for TB as early as 1994-96. Both the research were going on at the same time. But there was no clue at all, because culture was negative, smear was negative, PCR was negative. It appeared as if all the gates were closed and there is no clue. And the literature only talked about juvenile rheumatoid arthritis because they were American textbooks. There is nothing about pediatric uveitis in American textbook. So it was a very, very pessimistic end at the year of 96. Then 98, I was very, very lucky to have 4 children from same village called Sellanendal. The village was near Pudukottai, city Pudukottai. And the 4 children were very enthusiastic. I asked them, how come you are from same person from same village, 4 children? And he was very happy to say that we are not 4 children, we are 41 children in our village with eye disease. I was so surprised. And they told they get eye disease after taking bath in the river, in the pond. So I visited and I saw really 41 children, and it was very surprising. They all were looking alike, and 7 to 11 years old boys. And I went and visited. GN Madam was very, very helpful. She gave me a van and team of people to go for a camp, UVIT's camp. And the village pond was so dirty. And when I saw the water under microscope, I saw so many organisms like this. It was so dirty. And then I sent a sample. I came to know that there is one institute called King Institute for Water Analysis. So I sent the sample and I was waiting that I will get the results. But unfortunately, I had the result as it is a non-drinkable water. So it was very disappointing for me to receive this information. However, we started conducting camps again and again, and I took the patient to the theatre and I just operated upon them. I removed the samples. And there was 2 more scientists, Dr. Narsingh Rao, my mentor and my teacher, who is a fantastic person, who studied this. I stored all these samples in paraffin blocks. So I asked him, when I visited Netherlands for leptospirosis training, I met him there. I asked, I have paraffin blocks, I have village with so many samples, can I give the samples to you? He was immediately accepting without spending even single paise. I sent the sample to Los Angeles through volunteers, and he found out 3 samples with trematode granulomas. It was, I sent 43 samples. Out of 43, only 3 had trematode granulomas. And that was published in American Journal of Ophthalmology and Ophthalmology. Now, at least there is a full stop about TB. It is not TB anymore. It is only parasitic. But the thing is, when I went into the literature, I learned that I'm not an ornithologist to know the birds. So I studied a lot about ornithology, zoology, everything. And I came to know that the birds carry adult worms, and they shed eggs in the water, and eggs hatch, and the first larva come out, enter the snails, second larva come out, which is supposed to go to the bird eye, but it affects the human eye because they are playing there. I just took the snails and I cut, and I was not seeing any larva. So then I thought it is the end of my research. But luckily, I went to China for another conference. The zoologist told, he laughed at me, what do you want to cut the snails? Put it in water, it will come out on its own. I put it in water and the larva came out. And then again, I visited the pond. I collected so many snails. Now the problem is so many snails and so many trematodes. So we do not know which snail is causing so many snails and so many trematodes. Which snail we will not know. So we did we thought we should go for molecular diagnostic. An angel came in my life. She was doing molecular diagnostic in parasitology, and she did DNA preparation, PCR, real-time PCR, molecular sequencing, and blast analysis. And finally, we came to know that it is trematode procervum, and we published in Archives of Ophthalmology and emerging infectious diseases. So we had the path and we know the answer also. We do not treat with empirical anti-TB drugs. When we are in doubt, do RT-PCR. When you are thinking that it is TB, we educated the villagers to avoid contaminated ponds. We advise them for cleaning the ponds. So it is not TB, it is trematode granuloma. So the second disease is over. I will finish the third one soon. the molecular diagnostic of West Nile virus. See, there was a newly married man. Fourth day, he had fever. He became drowsy, and he was admitted in Meenakshi Mission Hospital. And it was viral encephalitis. The painful thing is, seventh day, he lost both eye vision. It was bilateral arterial and venous occlusion. So the retina was flat like this. He became permanently blind. After that, I had several patients like this. Several patients. Again, it was 2,000 cases in with the history of fever. So what we routinely did everything, nothing was positive. We even sent the sample to France lab for rickettsia and Bartonella. That was also negative. Then we wanted to check for dengue and chikungunya in Gwalior lab and virology division. And they told that it is West Nile virus. But they gave possibility of dengue 18%, chikungunya 21%, and West Nile virus 33%. I cannot tell the patient that you have these many percentage of chances of diagnosis. So what I did is I asked them to go for molecular diagnostic. They had lot of funds because it is a defense research lab. So they did PCR, RT-PCR, everything, and then finally found out that it is only West Nile virus. And now we have, beyond doubt, we have proven all the three entities. And now our idiopathic cases, we are slowly bringing down below 50%. Thank you.